Welcome to our webinar, Path 203, Modeling with Path Study Data Survival Analysis. We are your hosts, Dr. John Upsummer, Vice President of Statistics and Data Science at Westat, and Dr. Xiaoshu Zhu, Senior Statistician at Westat. A link to a transcript that includes descriptions of all complex images and information is available in the YouTube video description. Disclaimer, this is not a formal dissemination of information, and the views and opinions expressed in this presentation are those of the authors only and do not necessarily represent the views, official policy, or position of the U.S. Department of Health and Human Services or any of its affiliated institutions or agencies. Let's start with an outline for this webinar. First, we will discuss discrete time survival analysis. Then we will show some more advanced cases, for example, the type of analysis that you might want to do with covariates, either time-independent or dependent. And finally, how starting at different waves impacts the analysis. We will begin with discussing survival analysis with discrete time points. We're talking about discrete time survival analysis because that's almost always the type of analysis you're going to do with path study data, because it's collected in discrete time intervals called waves. In other words, you don't really observe time, you observe waves. You start at wave 1, and then you go to waves 2, 3, 4. In survival analysis, the starting point is typically called time 0. Then the steps are 1, 2, 3, 4. But I'm primarily going to use the wave terminology. So time 0 is really wave 1, then time 1 would be wave 2, etc. For this first part, we're going to look at an example where we're starting with people who do not use tobacco products at wave 1. Then we want to know what's the probability that they start tobacco use at waves 2, 3, 4, 5, etc. Let's begin at a high level with the basic concepts. When conducting a survival analysis, the random variable in such an analysis is capital T. That's the random variable. That's the wave at which the event of interest occurs. In this case, the event that we're looking at is, for a given person who does not use tobacco, when do they switch to become a person who uses tobacco? At which wave does this happen? We're going to treat this event as a random variable, which can take on values little t equal to 1, 2, 3, etc. The random variable capital T has a probability distribution function over these values. But in survival analysis, what you are typically interested in is a survival function or a hazard function rather than a distribution function. And the survival function, written as S of t, is the probability that the switch happens at a time that's later than some fixed time little t. And so that's the probability that a person who does not use tobacco is still not using tobacco at wave t. You can also write this as 1 minus the probability that capital T happens before time little t. That's the cumulative distribution function, or the failure function. So the survival function is 1 minus the failure function. They're really equivalent, but people typically think of survival function. The other one that's used is the hazard function, and this hazard function is a conditional probability. The conditional probability asks, given that we know that the random event time, capital T, is equal or bigger than little t, what's the probability that something happens at time t? The hazard function, h of t, is the probability that a person who does not use tobacco becomes a person who uses tobacco at wave t, among those who have not become people who use tobacco prior to wave t. For somebody who has survived up until time t, what's the probability that this event will happen at time t? Typically, survival models are expressed in terms of the hazard function or the hazard rate. But once you have the hazard rate, you can compute a survival function. Ultimately, if you know one, then you know the other because they're fixed functions of each other. In practice, this random variable t, the time at which an event occurs, is rarely observed over the whole possible duration, meaning all the possible times at which the event can occur. It's almost always censored. The most common censoring is right-censored, which says that we don't observe t, we observe t if it's smaller than its censoring time c. And otherwise, we just know that t happened at some future time later than c. Put another way, we observe the minimum of t and c, where c is the censoring point. As an example, if c, the censoring, is at wave 5, in that case, what we observed is that a person who does not use tobacco has either switched to tobacco use at waves 2, 3, 4, or 5, or it's something bigger than 5. In other words, if it hasn't happened by wave 5, we don't know when it's actually happening. We just know it's going to happen in a wave later than 5, for instance, wave 6 or 7. It's very common that you only observed a fixed period of time. The event happens either in the interval or later. And that's the censoring that we're going to use in this webinar. Although you can also have left-censored data so that t is only observed when it's bigger than some time point, or interval-centered when t is only observed to happen between a lower bound and a higher bound. But we're not going to talk about those. We're really only going to talk about the analysis of data that are right-censored. In practice, if you're fitting survival models to data, you have to specify the censoring. But that's all you have to do. The software will know how to handle it, so you don't have to do anything special in addition to specifying the censoring that you're using.
We will start with a very simple example. We will look at the wave 1 adults who never smoked cigarettes, and will model their probability of beginning to use cigarettes at future waves. We will use data from the first 5 waves so that the data are right-censored. In order to do that, we need some variables from several waves. First, we need the condition variable which identifies people who never smoke cigarettes at wave 1. Then we track those people from wave 2 through wave 5 to see whether they ever transition to smoking cigarettes during those waves. We will use the wave 1 cohort all waves weights for wave 5 adults to generate inferences for the population. All these variables are available from wave 1 to wave 5 in the public use files, or PUF. The condition variable, which we use to identify people who never smoke cigarettes, is RO1R_NVR_CIGS. And the outcome, the event that happened in the following 4 waves, are the ever cigarette use yes or no indicators. And the weights used are the wave 5 all waves weights from the wave 1 cohort. To begin the unweighted survival function manual calculation, we will subset those persons who never smoke cigarettes at wave 1 and can be tracked to wave 5. The total number of persons we identified is 4,281. At each wave, you can see there are new persons who start using cigarettes. Wave 2 has 192, Wave 3 has 102, Wave 4 has 81, and Wave 5 has 75 persons. When we rearrange all the numbers in this table, we are able to calculate those survival functions, their failure rates, and also hazard rates. The hazard rate is calculated as the conditional probability. That's the number of persons who use tobacco at wave T divided by the number of persons who do not use tobacco at wave T-1. And for survival, that's much easier or more straightforward than the hazard rates. That's just the number of persons who do not use tobacco divided by the number we start with. And the failure rate is 1 minus the survival rates. The reason we present all those numbers is to show you the output that's available from the SAS functions. Cumulative hazard rates is often talked about in survival analysis, And if you look at this cumulative hazard rate, it looks like a probability, but actually it's not a probability. It's simply the sum of the hazard rates. The reason why that matters is because it's common to think of cumulative hazard rates as the failure rate. In other words, what's the probability that something will have happened by wave 5? But if you compare the cumulative hazard rate column and the failure column, the failure column is the probability. If you look at the last row, the 0.1051 is the probability that somebody started tobacco use by wave 5. And the cumulative hazard rate is bigger because it's just the sum of the hazard rates. And for probabilities that are bigger, not for those low numbers, this cumulative hazard rate can go above 1 because it's not a probability. So I want to caution you not to think of cumulative hazard rate as a probability. It's just a sum of conditional probabilities, which doesn't mean anything in the probability sense. The only situation in which the sum of hazard rates or conditional probabilities is an actual probability is when the event can happen at every single wave independently of all the other waves. In short, the failure rate is what you want to use to make statements about the probability that something happens. I also want to note that these are the unweighted counts. We can output or generate the table in the previous slide from SAS. What we need to do before that is to define the censoring variable, which indicates whether this event happened or not. An event or censoring indicator like event underbar EVR underbar CIGS determines whether the event happened. We use censoring time or time underbar EVR underbar CIGS for when an event happened. It's when this average cigarette use indicator becomes 1. We will then assign a value of 1 to this event indicator. And if a person never uses cigarettes throughout these waves, they will be given a value of 0. For some examples we see online, people may call this variable the censor. Personally, I find it's a little confusing in the current example. I prefer to use event for this variable, which is clearer. So when events happen, that's a value of 1. You will see later in the model statement how we define the event. The next variable is the time to the event. We treat wave 1 as time 0. And when we track people to wave 2, if this event happens at that wave, we assign value 1. But if the event has happened in wave 3, then the time for the event is 2, and so on. But if the event never happens, we give the maximum value of 4. Before we get into any modeling, one possible way to examine the data we have so far is to use the non-parametric estimates of the survival function in SAS. One very convenient function is called prog life test. You can see here we can request several estimates from this function. The Nielsen statement is to request the cumulative hazard estimates, and we can also request to output some plots. Here we specify that we would like to have the survival estimates. And the at-risk statements request outputting the number of survivals at certain time points. CB is to get the confidence band. The time statement is required to specify the indicator of time to event and the event indicator. As I mentioned, when people defined the events as 1, they are saying we would like to track people who survived at the end of the study. So we are actually interested in the event of 0. That is how it's modeled. Here, we also provided some selected output. The first output is the number of censored and uncensored values. We can see this is the exact number we just saw in the manually created table shown on slide 11. We start with 4,281 persons, and by wave 5, there are 450 of them who transition to cigarette use, and there are 3,831 persons who never tried cigarettes by the end of wave 5. So the percent of censored cases is 89.5%. In this PROC live test output, you can create this survival function and cumulative hazard rates table. In the right-hand table is the survival rate and its stand arrow. By taking 1 minus the survival rate, we get failure rate. Under the Nielsen-Allen column are the cumulative hazard rate estimates and their stand arrows. In addition, we are also able to plot the survival estimates. You can see this is like a step function at each time point, where each step down represents the proportion of people who converted to cigarette use. By wave 5, the survival rate drops to 0.9. If you are interested in failure rates, one possible way to do it is to add the failure statement in the plots function. So this plot is of the failure rate. Recall that the failure rate is 1 minus the survival rate. That's why the curve starts from 0 and just keeps going up when some people begin cigarette use at each wave. If you are interested in the cumulative hazard ratio, there is another possible way to get this plot. We can use PROC PH-rig to get cumulative hazard plots. The basic setup is very similar with PROC live test, but instead of using the time statement, we are using a model statement. We will not be focusing on this function because it's used to get model estimates for the unweighted or simple weighted analysis. We will get to the modeling part using the past study weights later in our presentation. I just want to show you there are other choices for you to generate the plot if you want to explore the survival function in the data. Previously, you have seen all unweighted estimates. Once we apply weights, we can regenerate those tables. The rates definitely changed a little bit, especially when you look at the failure rates. If you recall, when we presented the unweighted estimates, the final cumulative failure rate was 0.1051. After we applied the sampling weights, such failure rates dropped to 0.0583. It's almost half of what we've seen with the unweighted data. That's why it's important to apply sampling weights for your own estimation, because using the unweighted data has misleading results. You can apply those weights to the non-parametric estimates in the PROC live test and PROC PH-rig. What you need to do is add the sampling weight variables to the weight statement. The outputted survival rate and cumulative hazard estimates shown in the table here are identical with what we've just seen in the previous slide. However, when you only enter the sampling weight and not the replicate weights, the stand arrows are incorrect. By doing the weighted analysis with live test or PH-rig, you get the weighted point estimates, but you don't get proper stand errors. We will discuss how to get proper stand errors soon. This slide shows you the survival function after applying the sampling weights. This slide shows you the cumulative hazard after applying the sampling weights.
Currently, we only look at the survival function of the outcome of interest, but for modeling, we will need to add covariates in our model. We will start with the simplest example where we add in the time-independent covariates. We describe the survival function and hazard function so we can see what's underlying this type of analysis. But what we're really interested in is figuring out the effects of the covariates on this hazard function or survival function. That's the main goal of this type of analysis. And the main model that's used for this is called the Cox model or the proportional hazard model. This model basically decomposes the hazard function into two pieces. And there's an assumption that's being made in this model. It's saying that the hazard function is composed of two pieces. One piece is this h sub 0, which is a baseline hazard. The other piece is this exponential part, that is the effect of the covariates. The thing that's particularly attractive about the Cox model is that you can estimate the effect of the covariates without having to specify this baseline hazard. So in principle, you don't even have to look at the baseline hazard. You often also do an estimation of the baseline hazard function, but it's not required. The key thing about the proportional hazard, or the Cox model, is that you are assuming that the effect of the covariates is the same at all time points of your analysis. And that's simply because you're able to divide by the baseline hazard. So the goal of these analyses is to estimate those parameters, or those betas. That's what you want to find out. Proportional hazard is a typical model that is available in most major statistical packages, including SAS. SAS has the advantage that it can fit the proportional hazard regression model for both the unweighted analysis with pH-reg or the weighted analysis with survey pH-reg. Now, pH-reg can also do a weighted analysis because it will take a weight statement, but if you do that, the standard errors are incorrect for a proper survey data analysis. So typically, pH-reg is what you want to use for unweighted, and survey pH-reg is what you want to use for weighted.
Let's revisit our first example. Now we would like to add some covariates to our model. What we selected are some demographic characteristics we measured in Wave 1, which are available in the public use files, PUF. As you can see here, we selected three characteristics: age, sex, and race and ethnicity. We recoded those variables to simplify the interpretation of the model. Specifically, we created 6 categories for the age variable, 2 levels of sex, and 4 levels for race and ethnicity. We can explore the association of those covariates with the survival time using proc-life test. We do this by adding the covariates to the test statement. From the test statements, we were able to generate chi-square tests, as shown here. There are 2 types of chi-square outputted from SAS proc-life test. The first one is the univariate chi-square test, and the other is a forward stepwise sequence of the chi-square test. The univariate chi-square test examines the association between the covariates and the outcome individually, and the forward stepwise examines the joint effects of the covariates. It will give you a sense of which covariates have the strongest association with the survival time. For our current example, age shows the strongest association. The difference between the Wilcoxon test and the log-rank test is how they weight the events. The Wilcoxon method places more weight on failures that happened at earlier time points, whereas the log-rank test weights the failures that happen at different times equally. Usually, we just look at the log-rank test. Once we learned that age has the strongest association with survival time, we were able to generate the survival function by age category by adding the strata statement in Proc's life test. You will see that SAS outputs the number of failure and censored cases by the age categories, and an equality test to evaluate whether such survival function is consistent or equal across groups. The small p-values indicate that the survival time differs across those age groups. The table and plot on this slide show the survival function by age category. From the plot, you can see that more young adults, i.e. 18 to 24 years old, convert to cigarette use by the end of wave 5 compared to the other age groups. You can get the similar cumulative hazard rates by strata from Prague PH-REG, but it requires some additional work. As you can see here, we defined a dataset called age, output all 6 age categories, and use the baseline statement in Prague's PH-REG to get the cumulative hazard rates by age category. It's a similar conclusion for the youngest adult group. The cumulative hazard is much larger compared to the other age groups. In addition to the relationship between individual covariates and survival time, we are more interested in the joint effects of all those covariates. Now we would like to introduce you to a different example. Here we are interested in adults with gum disease. We would like to see among wave 1 adults, at which wave in the following 4 waves did they report having gum disease in the past 12 months? How are the demographic characteristics associated with disease time? After controlling for the wave 1 gum disease status, we will see there are several layers of information we need to incorporate into our model. The outcome of interest is whether they report gum disease in the past 12 months. For the covariates, we will stick with age, 6 options, sex, 2 options, and race and ethnicity, 4 options, as they are all time independent. Here, I need to make a note that sometimes people treat age as time variant. That is, it changes across time, but we are classifying it as time independent in this example. That means we will treat it as a fixed value. Conceptually, it really is time invariant because once you know the person's age at wave 1, you know all the ages after that. It doesn't really vary in that sense, even though the age goes from 18 to 19 to 20, etc. It's not varying because it's fixed once you know the beginning age. Here, we just use the baseline or the wave 1 age for this information. In the context of the past study, it's almost always going to be more appropriate to use age as time invariant. Later, we will use the time variant variable, and you will see conceptually why age is in fact not varying, while those variables truly are varying. While we explore the association of those demographic characteristics, we would like to control for the fact that some people probably already had gum disease before the study started. That's why we have included a control variable for whether people report that they ever had gum disease at wave 1. Again, for the weights, we are using wave 1 cohort all waves weight for wave 5 adults, because we are tracking those people through all 5 waves. Let's look at the variables we are going to use for this second example using the waves 1 through 5 paths. AX0129 asks people whether they have had gum disease in the past 12 months. This is the outcome we are interested in, and for the control variable, we use the ever had gum disease question in wave 1. Again, we need to define the censoring variables. The event of interest is whether adults reported gum disease in the past 12 months from wave 2 to wave 5. If they reported it at any wave, the event gum disease will get a value of 1. If it never happens throughout all 4 waves, it will be assigned 0. Based on the interview questionnaire, there are 4 possible combinations of responses that indicate the adults who never reported having gum disease. The conditions with a value of -1 are to capture adults who didn't know or refused to respond to the 12-month gum disease questions. The time to event variable is defined by the earliest wave when adults reported gum disease. For easy interpretation, wave 1 was defined to be time 0. So if gum disease was reported in wave 2, the time variable gets value of 1, and so on. If it never happens, we will give it the value of 4. We would like still to explore the association between the covariates and the survival time before we run the model. We are using proc life test again, and we did the test with the control variable and the 3 demographic characteristics. Here you can see that from the log-rank test under the forward stepwise sequence of the chi-square test, the people who ever report they had gum disease have the strongest association, followed by sex, age, and race and ethnicity. However, everything is unweighted so far, and we know that when we apply the sampling weights, the conclusion may differ. Next, we need to apply the survey weights to our analysis with the Cox proportional hazard or Cox pH model. To do this, we need to use proc survey pH rec. In proc survey pH rec, we need to specify the dataset we are going to use and whether to subset it. We only look at the people who have non-missing values on the time to event variable. For any adults who didn't follow the pattern we used to define the censoring event, they will be excluded. And the variance estimation method is BRR with a phase factor of 0.3 as used in the past study. The other specification is very similar to what we used in the pH rec statement. In the model, we have the time and the sensor event indicator. The CLPARM statement requests the confidence interval of the parameter estimates. The last 2 statements specify the weights and replicates weights that should be used for this weighted analysis. Now, let's look at some results. The first one is similar to what we have seen in pH rec. It summarized the number of events and censored values, in addition to the weighted counts. If you recall the first example, we saw a big difference between the weighted and unweighted percent of censored cases. But this time, these 2 numbers are pretty close. Now, let's look at the parameter estimates in our model. The first 2 rows are for the control variable, and the estimate is positive. When the estimate is positive, the hazard ratio is larger than 1. This means, compared to the reference group, the risk of having or reporting the event is higher for the comparison group. For example, for people who ever report that they had gum disease at wave 1, the risk for them to report gum disease in the past 12 months in the following waves is 8 times higher than people who didn't report gum disease before wave 1. You will see that for age, sex, and race and ethnicity, all the hazard ratios are larger than 1. For age, we use the youngest group as the reference group. For sex, it's male, and for race and ethnicity, it's non-Hispanic white. Some effects are significant, except for the oldest adults, those 65 and older. The other adults, that is 25 to 64 years old, all have a higher risk to report gum disease in the past 12 months compared to the youngest adult group. Sex is not significant, even though females are showing a little bit higher risk for reporting gum disease. In terms of race and ethnicity, the only significant group difference is found between those who identified as non-Hispanic Black and those who identified as non-Hispanic White. Specifically, among those who identified as non-Hispanic Black, the likelihood for them to report gum disease is 21% higher than those who identified as non-Hispanic White. Next, we would like to look at discrete-time survival with time-dependent covariates, also called time-varying covariates. From its name, you can surmise that these covariates vary across time. We selected alcohol and tobacco products used in wave 1 adults for the following 4 waves. We want to test whether they have an association with gum disease reported in the past 12 months. We also want to observe how demographic characteristics and alcohol and tobacco use correlated with disease onset after controlling for wave 1 results. You can see here the definition for those time-dependent covariates. Alcohol use was defined as having alcoholic drinks in the past 30 days. The specific tobacco products of interest were current established cigarettes used or current established electronic nicotine products used at each wave. Those things can be temporary, and such status may change across waves. That's why we would consider them as time-dependent or time-varying. Time-independent covariates include the previously described demographic characteristics of age, sex, and race and ethnicity. Another covariate is the control variable, that is, if adults at wave 1 ever had gum disease. To reiterate and highlight the difference between time-dependent and time-independent, once you know the age at wave 1, you know the age in later waves. Even at wave 5, you know how old they are if you know their age at wave 1. In that sense, it's not time-dependent. But for a time-dependent variable like alcohol use, if you know the alcohol use at wave 1, that doesn't tell you the alcohol use at wave 2 or 3 or 4. It's related, but it's not fixed. So this is the difference between the two. The time-dependent variables need to be combined from several waves. As you can see here, I used ROX instead of a specific wave to indicate those variables. When we merge them together, you will see there's a set of indicators for alcohol use AX0075, which is defined as the number of days people reported they had a drink, even if it's just one or multiple sips. You can also see whether they report current established use of cigarettes or e-products at certain waves. Before we run the model, we need to manipulate these variables. First, we will rename the variables and recode them for a more straightforward interpretation. As you can see here, I renamed alcohol use to ALC use _1234. I will show you later why we need to do this. It's required for the model specification to handle time-dependent variables. We did a very similar thing for current cigarette use and electronic nicotine product use. We renamed everything by adding a suffix with 1, 2, 3, 4 to indicate at which wave this information was available, and also to recode them to 0-1 binary indicators. Now we come to the Prague survey pH reg again with the Cox pH model and the time-dependent predictors. Everything else is very similar, but you can see we have 3 additional variables added to the model statement. They are alcohol use, current cigarette use, and current e-product use. You may recall that those are not the variable names we used in the previous slides. There is a nice function that is offered in SAS to handle time-dependent variables. We define 3 arrays for the 3 time-dependent variables. Then, at certain waves, the array variable takes the value of the time-dependent variable at that wave. That's why we have to rename the original time-dependent variables with consistent naming patterns. This is one way of defining it. There are other ways to achieve the same purpose. You can check the other examples using Prague survey pH reg with time-dependent variables to see how they are defined, but the basic logic is the same. Again, we add the sampling weights to the model. Once we have defined those time-dependent variables, we run the survey pH reg model and get the similar model coefficient estimates. We have the unweighted and weighted censored events, and we got estimates for all our covariates in the model. You can see that, in addition to all the time-independent information, we now have the estimates for those 3 time-dependent covariates. Among those 3 time-dependent covariates, the only significant effect is the current cigarette use, and the hazard ratio is larger than 1. That means for any people who report that they are currently using cigarettes, the risk of them reporting gum disease in the past 12 months is 1.15 times higher than people who are currently not using cigarettes. No significant effect was found for alcohol use or e-product use. Another interesting thing I would like to point out is that I had noted all the hazard ratios for those time-independent variables were over 1 when we didn't have the time-dependent information. For example, before the time-dependent covariates were added, the oldest age group didn't show a significant group difference compared to the youngest age group, but now it's significant, and the risk of the people 65 or older to report gum disease is smaller than that of young adults who are 18 to 24 years old. This is not necessarily contradictory, because we are feeding a different model with additional variables. And for race and ethnicity, if you recall, the significant effect was found between those who identified as non-Hispanic Black and non-Hispanic White. But now the only significant group difference is coming from those who identified as Hispanic versus those who are identified as non-Hispanic White. We have to be very cautious when we interpret our model with or without those time-dependent covariates, since having that information in the model could change the conclusion of our estimates. It's possible to use statistical model selection approaches to decide which model and hence which estimates are more likely to be correct. However, that is beyond the scope of this introductory webinar. Next, we want to address how to handle data where people may start at different time points. For example, not all respondents have their first interview at wave 1. In order to address this issue, we will change our example a little bit. Here, instead of looking at the adults from wave 1, we focus on respondents who were used at wave 1 and track them until wave 5. Once the youth turned 18, they started completing the adult interview. We call them aged-up adults. The youth may become aged-up adults anytime between wave 2 to wave 5, but our study period stops at wave 5. We would like to see until wave 5 whether those aged-up adults reported gum disease in the past 12 months at any wave between their first adult interview and wave 5, and how the demographics or alcohol and tobacco products use will be associated with this disease time. The reason that we are interested in aged-up adults is because they may leave their house and live on their own, so their hygiene behavior could change. As a result, their gum health may be affected. This group of aged-up adults will have the same endpoint for the study, but they will have different starting points. What we need to do is recode all those variables so everyone will have the same starting point but different endpoints. How will we do that? We will stack those data into a noun format. This is called the counting process approach, and we will show you how it's done in a few slides. Previously, we used the programming statement approach, so it's very inconvenient just to rename all those variables. But this example is more complicated than the previous one. For this counting process approach, it's preferable to have multiple time-dependent variables. You are able to get some additional estimates, such as stand errors or other effects from the model using this approach, but it definitely requires more work. The variables are the same as in the last example. As a refresher, we want to test the association between drug and alcohol use and the onset of gum disease reported in the past 12 months across waves 1 through 5. We continue to control for wave 1 results where we ask adults if they ever had gum disease. For this example, the time-independent and time-dependent covariates are the same as before. The one additional piece of information we need is the indicator for aged-up adults. Looking at this chart, which lists the variables that will be used in this particular example, you can see that we start with wave 2 new baseline adults, or aged-up adults. For each wave, we only select those people who are new to the adult interview. The outcome is still whether they report gum disease in the past 12 months, and the time-dependent variables are still alcohol, cigarettes, and e-products use. Now, we don't need the suffix like 1, 2, 3, 4 for the equivalent questions from different waves because it's now in a noun format. We rename them to the same variable name before stacking them into one column. And for the time-independent variables, we will simplify and only use sex and race and ethnicity. We also would like to control whether they report ever having gum disease at their first adult interview. That's the new baseline AX0129 variables. For the weights, those are still the all waves weights for the wave 1 cohort. Next, we will define the censoring variables using event underbar gum disease. It's straightforward to define the censoring event variable. Whenever that event happened, we will assign a value 1. If it never happened, then it's 0. But we will need additional manipulation of our data when defining the time variables. Specifically, we need to define the starting and the end time for our events. Now, the data is in a long format where each respondent will have multiple rows. Each row contains the information of one respondent at one time period. In our example, a time period means a wave. Wave 2 is the earliest wave the aged-up adults started completing the adult interview. The first answered the new baseline question AX0129 underbar NB. Then in wave 3, they answered the past 12 months question AX0129_12M, which is the censoring event we are interested in. Therefore, the earliest wave that the event could be reported in is wave 3. As shown in the examples here, the event's wave column has wave 3, 4, and 5 for respondents 1 and 2. That means they were aged-up adults in wave 2 and responded to the past 12 months gum disease question in wave 3. In wave 5, respondent 1 reported gum disease in the past 12 months. Whereas respondent 2 had no gum issues through wave 5. Respondent 3 took their first adult interview at wave 2 and reported gum disease in the past 12 months in wave 4. And respondent 4 has only one row because they started in wave 4 and the study period stopped at wave 5. As mentioned in the previous slide, we will give the respondents the same starting point. Therefore, the value of start for the first record for any respondent is 0. Then the stop on the same row will be start plus 1. The SAS code here shows you one way of defining the time variable in the long format. In the counting process, when the time-dependent covariates have the same pattern, we could collapse the observations. For example, respondent 2 only takes one row in the data, but the stop equals 3. This means the values of the event underbar gum disease and the 3 time-dependent variables didn't change across the 3 waves. In the data, we only include the distinct pattern of those time-dependent covariates. Here, we provide an example SAS code to show how to collapse the records with the same pattern, but we will not go into detail for this webinar. Once we finish defining the censoring event and leaving distinct patterns of covariates, we can run the analysis using these 2 pieces of information using proc survey phreg. The only change is we now replace the time variable with the star and the stop variables. Here you will see that the time-dependent variable doesn't require any additional work because it's just one column per variable for the time-varying information. Here are the results. Very similarly, we got the unweighted, weighted, and the censored counts. This shows the estimates for those covariates in our model. The p-values in the table on the right are showing that for the aged-up adults, only current e-product use has a significant association with the outcome, and is positive. When aged-up adults report that they are currently using e-products, the likelihood or the risk for them to report the gum disease in the past 12 months is 1.9 times higher than people who didn't use the e-products at a certain wave. And for the other control variables and the demographic characteristics, it's only the control variable ever had gum disease when first taking the adult interview AX0129_NB showing strong association, which makes sense. If you report ever having gum disease before you had your adult interview, the likelihood for you to report gum disease again in a future wave is 17 times higher than the aged-up adults who never report having gum disease.
To summarize what we have presented today, we covered the basics of survivor analysis, showed how to perform survivor analysis with survey data in SAS, and provided several examples of simple analyses using path study data. Path study data are a rich source of longitudinal data and will become even more so in the future as additional waves are added. This webinar was an introduction to survivor analysis, but it is possible to set up and fit more complicated survivor models for your particular research questions. If you have any follow-up questions, you can email your questions to path data user questions at westat.com. Thank you. Funding. This presentation is supported with federal funds from the National Institute on Drug Abuse, NIDA, National Institutes of Health, NIH, and the Center for Tobacco Products, CTP, Food and Drug Administration, FDA, Department of Health and Human Services, under contract to Westat. Contract numbers HHSN 2712011000027C and HHSN 2712016000001C, and the collaboration between NIDA and the National Cancer Institute, the National Institute on Minority Health and Health Disparities, the National Heart, Lung, and Blood Institute, the National Institute on Alcohol Abuse and Alcoholism, the National Institute of Environmental Health Sciences, the Office of Behavioral and Social Sciences Research, the Office of Disease Prevention, the National Institute of Diabetes and Digestive and Kidney Diseases, and the National Library of Medicine, and through an interagency agreement between NIH NIDA and FDA CTP.